fact that they can be considered, we can say, post taking advantage of the mechanical stabilization of slide screwing, or in severe cases I switch, few cases I have to be honest, to cast post with gold alloy. This where anatomical spaces is not rounded and it is not possible to stabilize the Datus post in any way. Or if I have, this is another indication, if I have an emergence of the post that forces me to cut the post so that the built-up material is mainly composite. What do I mean? If I have an incisors that it is not aligned, if I use a dentatus post, I have to follow this anatomy, okay? But if I want to make a straight tooth like this, the post is useless. Instead, if I want to use a cast post, I can do the modulation of the cast post so that the part that it is inside the root is with this axis, but after I have this sort of anatomy. So I can match the post to the future anatomy that I want to obtain. When I use, dentatus post come in different sizes, short 7mm.8, medium 9.3, long 11.8, XL 14.2, and SL super long 17mm I don't have. And they come in 6 sizes, 1, 2, 3, 4, 5 and 6. Honestly, I use the smaller post that I can, just removing the Buta perk that I did in my endodontic treatment. In most of the cases, I use the number 1 and 2, and in most of the cases, I use the medium or the long. This is, of course, it may happen that if I do maybe the palatal, if I put a post in the palatal root of a molar and it is bigger, I can use also a 4 on the 5, but this is because the anatomical space is already big, not because I do drilling in that area in order to fix the post. And this is what I do. I fix the post after I fill everything with the build-up material and the glue. I just want to share you a video of placing the dentatus post. I clean everything exactly like a fiber post. I do the bonding. Procedure with etching, rinsing. I put the adhesive. I rinse. Another important thing. I realized that when you work in the root canals, in many cases you are not able to make it dry just with the air of the syringe. So I always advise to use paper. I put the cement with a small applicator, with a small tip. I put the same cement, this is Varilink, I put the same cement on the tip of the post and I screw. And when I see that the post is stable so that I can remove the screwdriver without problems, I remove the post. I don't want to tighten so much, just a little bit of mechanical stabilization. I polymerize and after I fill everything with a little bit of composite, flowable, packable material, what do you want? In order to create again an abutment that we can drill for our future crown. I do this usually in a freehand motion, also because with vertical preparation, even if we have some overhangs in this part, it's very easy to trim everything. And in my experience, it's much better to have overhangs than to try to be precise, because when you want to be precise, in most of the cases you will end up with some voids. Instead, when you go overhanging and after with a bar you clean everything, the solution will be perfect. Look in the X-ray at your left, in the upper left corner, the post, the endodontic treatment, the perfect match without overhangs of the build-up with the tooth. And this is the final crown. Another tooth, look, fractured lateral incisor, isolation. I did the endodontic treatment. I always sandblast everything. This is a rule for me in restorative dentistry. Preparation for the post, look how small it is. Build up with the dentatus post, vertical preparation. Look how much ferrule we are able to rescue doing this sort of preparation, the vertical preparation. Initial and final, healing of the soft tissue after 10 days, 12 days, and placement of the final crown. Another case, fracture of the premolar with the fiber post. Isolation, new endodontic treatment, dentatus post, preparation for the vertical crown, time 0, provisional crown. Look here that the provisional crown is not in the sulcus, but it is 0.5 mm subgingival. Final crown, monolithic zirconia crown. Another case, 2 premolar with an old endodontic treatment. Patient came to my observation because she experienced some pain during biting, and during the CBCT there was a small lesion, but these teeth were tender to percussion and biting, so I did new endodontic treatment. This is the isolation. I was not able to seal the distal margin just with the matrix, so I added some Teflon. Even here I do overhangs. I just want a dry field for adhesion, for a clean adhesion, but I don't expect to do a clean restoration. But look in the X-ray, after with the vertical preparation I'm able to smooth everything. The new endodontic treatment, as you see in the X-ray, vertical preparation. Here you see that despite doing the vertical preparation, so quite a conservative technique, the pattern wall that was already something like 0.5 or 1 millimeter is almost disappearing. So this is the reason because I placed a post, because the walls were very thin and I cannot rely on them. Day 0, healing after 1 week. And this is the crowns. These are the crowns. Occlusal and labial. When I use cast post, of course, I already told you the cases where I use cast post, and these are cases where the anatomy is not round enough in order to engage in a proper way the dentatus post, because the stability is related to the screwing, to the engagement of the screw. But one of the most real indication is when the future emergence is not with the same axis of the root axis. What is interesting is that nowadays, with a small help by our technician, we can work also in aesthetic cases with some cast post. And so we can apply the cast post advantages of stability, emergence profile, and strength to the aesthetic. What do we do? This is a case I did myself with a fiber post after around 8 years I had the fracture of the fiber post. So I have to move to something different. This is the impression for the cast post. This is the model in polyurethanic resin. Okay, my technician do the waxing for cast post, but he does a reduction in order to accommodate some space for ceramic. It's like a small crown, okay? So this is the waxing. This is the cast post before the lining of the ceramic. Opaque, it's like a small crown. And the ceramic. And this is the aesthetic cast post that sometimes I use in my office, just in some selected cases, but this is a good option. The advantage is that having ceramic, you have no problem of a bad ugly color to height. Being ceramic, you can also use hydrofluoric acid and do adhesive cementation. So if you want to use lithium disilicate or something like this, you can perfectly bond, because this is feldspathic ceramic. So you can really bond something on. So you keep the door open for adhesive cementation. And this is what I was speaking before. What I use nowadays FiberPost for the provisional phase. You see what I did? I used the old crown and I realigned the old crown together with the FiberPost inside the root canal prepared for the cast post. These are perfect in my experience, because you are able to place in a stable way these crowns, but you are able perfectly to remove without so much effort, without the risk of damaging anything. This is the cast post, the aesthetic one, cemented. At third view, this is the work on the impression made by the technician, and this is the final crown. And now we are at 2018, the 4 years follow-up. This crown is still performing in a good way, despite working on a tooth that it is much more compromised than the original one. This is everything about the use of post. I hope that you have understood the rationality behind this choice. But I have to say that the clinical experience is supporting my decision. This is everything for this part of this video. This has been a pleasure to share this with you. See you again with the other videos of this video course. Bye guys!